Good evening, everyone, and thank you for joining us for Season 5, Episode 6 of Doc Talks with Dr. Forrest Tennant and friends. We have an exciting show ahead of us. So, Dr. Tennant, it's all yours. We thank you so much.
Thank you, Jamie. We are going to have an exciting show. I've got what I think is a very exciting announcement coming out of our research studies. We're going to have a nice discussion with Dr. Guess and Dr. Ibsen about what I call the propaganda against pain patients against opioids. And then we have that brilliant young man, David Smith, who somehow manages to deal with the judiciary and has filed a lawsuit to benefit a lot of people. And so we're going to get started. Now, the first thing we're going to cover today is another chapter, if you will, on our studies on deterioration of severe pain problems. Now, I think, again, most of you know that our focus disease has primarily been adhesive arachnoiditis, mainly because adhesive arachnoiditis is kind of the end of the road. In our studies, we have found out you just don't get that disease until you've already had slip disc, CRPS, fibromyalgia, Ehlers-Danlos. In other words, it's kind of the end of the road. And we have been studying people to know who deteriorates compared to those who are doing very well. And we've adopted the Epstein-Barr virus, not out of choice, but because this virus has shown up as a major causative factor in adhesive arachnoiditis. And I truly believe it's also a major factor in those people who have CRPS, post-stroke pain, small fiber neuropathies, pudendal neuropathies. We don't have as much data on those particular diseases as we do adhesive arachnoiditis, but I'm going to guess it applies. Now, what I'm going to talk about tonight may sound like it doesn't even belong on this show, but I am convinced that the Epstein-Barr virus situation is one that's going to have to be known not only by medical practitioners, but certainly by people who suffer its ill effects. Now, very quickly, the Epstein-Barr virus enters the body when you're usually about 1 or 2 years of age. Some people catch infectious mononucleosis, which is really the Epstein-Barr virus, in their teens or their 20s. And then the virus settles into the lymphocytes of the body and into the throat membranes as a normal parasite. Now, what has made the Epstein-Barr virus come to the forefront is the testing technology involving the virus. Okay? In other words, we couldn't be giving this presentation 5, 10, 15 years ago because we didn't have the testing technology. Now, I'm going to give you a little typical case here for a moment. I'm going to show you a lab report in a second from a young man. He's only 45. And he has ended up in his doctor's offices, and he ended up there kind of as an emergency with a slip disc or two, but he also had arthritis, had a little depression in his life and some other ailments, and he's doing very poorly. And his doctors have taken his Epstein-Barr virus panel, and he shows something that is very typical that I want everybody to know. It's kind of a first in medicine. Now, if you call Life Extension, and even without a doctor's order, you can order the 2 major antibodies to the Epstein-Barr virus. Okay? Now, one of them is called the viral capsule antibody, and the other is called the nuclear antigen antibody. Those 2 antibodies. Now, antibodies are really made by the body to protect you. You get antibodies after a vaccine, you get antibodies after you have measles or chickenpox, and they protect you the rest of your life from getting the disease again. That's what an antibody does. Now, it turns out that all of us, if you take our blood, have a normal level of Epstein-Barr antibodies, just like most of us have a normal level of chicken pox or of mumps or measles, you have a normal level in your blood. It turns out that the virus, the Epstein-Barr virus, can reactivate just like herpes can, and give you blisters on the genitalia or on your lips, or herpes or zoster or shingles, which is a reactivation of a virus. The Epstein-Barr virus can also reactivate, but it doesn't cause a skin problem, so you really don't know it's reactivated, although you may feel like you're sick. Now, this man we're talking about here, his panel comes back, and his viral capsule antibody is over 750. Now, the lab can only measure 750 units. It can't even go above that. What's normal? 20. In other words, the lab can measure around 37 times normal, but he has an antibody level over 37 times normal. Okay? Now, the lab is just going to say, this shows you had a prior infection. Well, you sure did, recurrently. In order to get this antibody level to this level, you have to have had multiple recurrent reactivations. Now, those reactivations may have been 3 days, and they may have been 3 weeks, they may have been 3 years. We don't know. We know one thing there, and looking at this young man who's 45, who's now got severe intractable back pain and does have adhesive arachnoiditis, we do know he's reactivated his virus multiple times in his life. I said his life. I'm going to say a few more words about it in our studies, but guess what? You may have started on the road to adhesive arachnoiditis when you were 15 years of age. You may have had your first auto accident. You may have gotten crushed in a football game. Okay? You may have gone to war when you were 20 and got hit with a grenade. Okay, you may have been in some domestic violence. What's interesting about this, we've thought about trauma being accumulative over time, but we doctors never had any evidence other than we kind of knew the patient tended to get worse with each traumatic incident. We now have evidence. It's the Epstein-Barr viral capsule antibody. It gets up to these levels of 750 only if you've reactivated it several times in your life, maybe for different reasons. And I'll come back to that. There are several different reasons why the virus will reactivate. Okay. Now, from a therapeutic point of view, the first thing this man needs to do in his life is to take some things to stop that reactivation. And we do have some things that work pretty well. There's been some good researchers, about 3 or 4 of them, have given us a list of medicinals. Most of them are natural, which will usually stop future reactivations. Not going to do anything about the past, okay? But might stop future reactivations. That's step 1 in dealing with the Epstein-Barr virus. When you've got an elevated viral capsule antibody, you've got to be on something to stop future reactivations. And I'll come back to that in a second. Now let's talk about the second antibody. It's the nuclear antigen antibody. Now this man comes back with a level over 600. That's all the lab can measure. It can only measure about 30 times normal. And his is higher than what the lab can measure. Now, what's important about the nuclear antigen? Listen up. This is new. This is profound. Matter of fact, I'm happy to tell people about it because it'll save your life. It'll stop the deterioration. It's your key to your future. On the other hand, I'm the messenger telling you that if you've got an Epstein-Barr nuclear antigen antibody this high, you've got trouble. You have got big trouble, and you're not going to get saved by opioids. You're not going to get saved by benzodiazepines. You're going to get saved only with anti-autoimmune treatment. Okay, now what about this nuclear antigen antibody? part of the antibody carries what is known as an autoantibody. That's brand new research. An autoantibody is something in the blood that eats away your tissues. That's the component that'll attack your discs, your muscle, your fibers, your small fibers, your arachnoid, your caudoequina, your glial cells. That's the autoantibody that attacks tissue, causes inflammation, adhesion, scarring, tissue destruction, and pain. And pain. Now, when we see a nuclear antigen antibody this high, this man will continue to deteriorate, we've determined in our studies, that he is just going to continue to deteriorate until he takes some medical steps. Now, what I'm saying is not going to be well received by a lot of people, because I'm here to tell you, and people can say if they disagree with Tenet, great, come up with your plan, folks. What we've seen in my studies is if you've got that EBNA antibody this high, you've got to stop that because we can't get rid of it. It is the same autoantibodies we think that causes rheumatoid arthritis or systemic lupus or scleroderma. We can control it, we can't get rid of it. Now, that's the antibody that tells us that person better be on corticosteroids. That problem better be on ketorolac. We've got doctors, like in Germany, are starting to put people on methotrexate. It's caused a few problems with some people. They're starting to put people on chloroquine. They're starting to put people on biologics, just like with psoriasis, because that's an autoantibody that's not going to go away, and it needs to be controlled. Or, I hate to say it, if I see somebody with this level of antibody to the nuclear antigen of the Epstein-Barr virus, I will just go on my record of saying you probably will deteriorate right into bed, right into paralysis and early death if you don't take medical measures to control that autoimmunity. Okay? Just to, before we go on, now let me give you one little bit of quick news, and we're going to summarize this and go on, because this is heavy stuff. I realize this. But for me, it's the first time we've ever had any hard objective evidence and pathway to stop some deterioration. Okay? Now, let me tell you what these lab people have come up with. I'm going to give you a list of the agents that are shown in the laboratory, not in humans, but in animals and in petri dishes, to stop the reactivation. And everybody who's got severe pain and who's got that high VCA antibody, here are the things that have been shown to stop it in the laboratory. First off, good old vitamin C, good old vitamin D, zinc and selenium, then curcumin, cimetidine, quercetin, resveratrol, luteolin, lysine, astragalus, and andrographis. Now, if you've got these high antibodies to Epstein-Barr virus, I suggest you be on at least vitamin C and one other thing in there. Okay. Now, if you find you've got the autoantibodies, I'm going to throw out here something that's becoming very popular. The agent monolaurin is becoming extremely popular. It's a derivative of coconut oil, comes in 3 dosages, get the highest one, and thymosin. Now, thymosin is sometimes known as the immune hormone. Okay, it's also a peptide. So thymosin, good old thymosin, you can get it. And interestingly enough, without knowing anything about Epstein-Barr virus, knowing anything about reactivation or autoimmunity, patients literally a decade ago in my clinic started telling me the thing that controlled their arachnoiditis was methylprednisolone or dexamethasone, one of the corticosteroids, and Toradol. Those 2 drugs, and guess what? We now realize what they were doing. they were suppressing the autoimmunity of the Epstein-Barr virus. Okay, we're going to close this out by saying this. These two antibody tests can be ordered without a doctor's order. You can call Life Extension, and they'll do it for you. They've got a contract, I think, with Quest, and I think it costs you $100, but you can get that test through them. I'm going to admonish anybody out here who feels they've got a severe intractable pain problem to get those two antibodies. Incidentally, there's a third and fourth and fifth test that have now come available for Epstein-Barr, and this young man, a third one was taken, and it showed that his virus was even active, and he's got to go on antivirals or antiparasitic drugs. So, but that's a third step. First two steps are critical, and for the first time, we can tell that people have had these things. In our deterioration studies, I've got some fascinating data real quick for you. We have learned, we asked 45 people with adhesive arachnoiditis documented what their inciting events were or their predisposing factors. All these are kind of risk factors. 88% had had a trauma in their life that they thought was severe. And they ranged from everything from domestic violence to falling off a roof to auto accidents. And 60% had some form of anatomic defect to their spine, scoliosis, spondylolisthesis, spina bifida, something like that. Severe infections, a third had severe infections like meningitis or Lyme, pneumonia in their life. 30% had infectious mononucleosis. About 20% felt that they'd had their spinal fluid contaminated during a spinal tap or an epidural injection. And only about 30% had autoimmune disease. 30% had Ehlers-Danlos syndrome. Bottom line is, these people who were in our studies had literally had a tough life, medically speaking, that had a lot of incidents. They had predisposing factors, and they didn't have any idea that underneath all this, the Epstein-Barr virus was propagating, reactivating, causing autoimmunity, and just kind of rusting them away until they finally hit a roadblock and were diagnosed with adhesive arachnoiditis. Anyway, I'm going to have to move on, but I find this very good news because I'm going to summarize it this way. If you have a terrible pain problem, you've got to take opioids every day, you're paralysis, you're in bed, whatever. If you've got a severe problem and you want to avoid deterioration, I think you better get these Epstein-Barr tests. Okay? All right. We're going to move on to...
Hang on just a second quick.
Sure.
Dr. Tennant?
Yes, Mark, you bet.
Yeah. So I have a question about the nuclear antigen antibody. And does that cross-react with a standard anti-nuclear antibody that's positive for lupus? Is there any available confusion there? I have some people who've had ANA positive, then it's negative, et cetera, et cetera.
Yes, it does. As a matter of fact, there's some belief that they're kissing cousins or the same one. Okay? And some have, and about a third of our arachnoiditis patients have a positive ANA. So, yeah, absolutely it cross-reacts. In other words, adhesive arachnoiditis really ought to probably be called an autoimmune disease right along with scleroderma and lupus or rheumatoid arthritis. Okay? Or psoriasis. Big one. Go ahead.
Dr. Tennant, can I ask you a question? I've been wanting to dying to ask you this one here.
Sure.
And particularly this phrase that he just came up with, a nuclear antigen antibody. Is there any correlation between, you see this Epstein-Barr virus as a causative factor in the disease state of ALS?
ALS. Probably.
Thank you.
The reason I say probably is what really got me. I'd been doing viral studies on intractable pain patients for many, many years, and I kept hitting a blind alley until there were some studies showing that the Epstein-Barr virus was probably the cause of multiple sclerosis. And when you look at ALS and then multiple sclerosis and adhesive arachnoiditis, you're talking about a brotherhood here. They're kissing cousins. You see a lot of people who have both multiple sclerosis and adhesive arachnoiditis, and a few with ALS.
Right.
So I can't help but feel that the viral reactivation, not just with Epstein-Barr, but maybe with some others, is something that with new testing technology, we're starting to diagnose this.
Okay.
With all the hubbub with the health system and with politics these days, you don't hear about the positive things. But these new laboratory tests and this ability to diagnose things aren't getting to the public. But I've got to tell you, as a long practicing physician, they're dynamite. If it hadn't been for this new technology, I wouldn't be talking to you like this. ALS, I'm sure that's got to be something to do with viral reactivation. That's just my guess. Okay?
Thank you.
I'm glad you asked that question because that's not the first time I've been asked it. And ALS is a terrible disease, just like these others. Okay.
Thank you.
Well, thank you. What I want to talk to next, we had a issue come up a few weeks ago, and that the ARUP magazine featured a story about the difficulty getting medical care, but there was a side article about the government's new study on high impact and chronic pain. And they put a statement there that was so, it seemed to me, out of line and so mischaracterized that I wanted to bring it forward. And Jamie, are you here to
Yes,
read
sir.
this to me?
Yes, sir. Yes, sir.
Now, what I'd like for you to do is I've asked Jamie to read a couple of sentences that were in the ARUP magazine. Now, this is important because, first off, if you don't know who ARUP is, it's the major retirement organization. I belong to it. I even belong to their health plan. Now, they are an arm of United Health. And I'm going to guess now that they're very anti-opioid, very anti-pain patient. They're, I guess, I hope not, but you kind of get that idea. At any rate, I wanted Jimmy to read a statement because I hope Dr. Guess is here too, at least Mark. We're going to talk about the propaganda that's gone on for years to besmirch pain patients, pain doctors, opioids, and people who are at the end of life. Anyway, would you read this, read what they said about the government's study
Yes, sir.
on high impact pain?
Yes, sir. I'd be happy to. Thank you. An article, and it's a small segment, like Dr. Tennant said. It is one small segment of a 48-page bulletin from the AARP January-February edition. And what it says is chronic pain surges among those that are 65 plus. But then it says chronic pain has reached alarming levels in the US, with nearly a quarter of Americans saying they had discomfort that had an impact on their daily life or work activities in 2023, and 8.5% reporting high impact pain, defined as pain that can cause opioid misuse, anxiety, and depression, according to the Centers for Disease Control and Prevention.
All right. Read that sentence again, just one very quickly, if you wouldn't mind.
Yes, sir. 8.5% reporting high impact pain, defined as pain that can cause opioid misuse, anxiety, and depression, according to the Centers for Disease Control and Prevention.
Okay. Now, what does that have a special meaning to you?
In my opinion, I just read this and it looks like they are blaming any person that has a high impact pain. They're saying that can cause opioid misuse. So a person that takes opioids is obviously has an opioid use disorder. It's no longer called a opioid abuse disorder. I'm not sure.
Now, the government in its report, which I have here, doesn't define high impact pain like that. it describes pain, high impact pain, as pain that interferes with one's daily life over a period of time. Now, Mark, I'd like for you to weigh in on this because this is the kind of subtle propaganda that's been used with alcohol, been used with cigarettes, been used with sugar, and that is it is the drug problem. It's the drug is the problem. In other words, the guy was at the bar, got drunk, had an accident, and killed somebody. And it's not the alcohol, it's not the bartender, it's the guy who abused it. Now, what AARP says automatically, if you're a high impact patient, you abuse opioids. Is that not what it says? Mm-hmm. Mark, are you there?
That's the implication. Yeah, I'm here.
Yeah. What? It, I mean, isn't that what they're really saying here?
Well, yes and no, I think. The yes part is it's wildly irresponsible to report data and then immediately in the same sentence imply that it is pain that can cause opioid misuse, anxiety, and depression. So it's pain that requires opiate use, but does cause anxiety and depression. So it's like saying insulin causes very high blood sugars.
Yeah.
No, insulin is used to treat high blood sugars. It's like saying atenolol or losartan causes high blood pressure. No, they are associated with high blood pressure because they're used to treat it. It is a rookie mistake by this journalist that was writing this article. So that's the bad news. The good news is the article. This is a small little segment of a very impactful article, and um, and we need to make corrections. But it does tell us that the narrative is um, that people will use statistics to make up any narrative they want, and the narrative is that Granny's a druggie, and
Mhm.
and I can tell you that my patients born before 1965 who have chronic pain, you couldn't talk them into using anything else than a legitimate pain medication for their pain. They are the most unlikely patients to use illicit substances, um, and and it's not an abuse of a substance when your doctor prescribes it legitimately for your specific instance. In fact, I'm sure you recall this too, Dr. Tennant, opiates are the safest substance to use for pain for anyone over 55 or 50. Non-steroidal anti-inflammatories cause GI troubles and renal failure. Tylenol causes liver problems. There are no end organ damages from any opiate that a patient can take. And so my training, which evolved and has been all over the place between yes treat pain and no don't treat pain, and that's been gone through that cycle at least 3 times in my career. My training has been you should not have any non-steroidals going into anybody who's over 50 or 55 because they're dangerous for the kidneys, and the kidneys are kind of important for people, particularly after they age. So yeah, uh, we could get carried away, but I think it's a great insight to notice that while an AARP is very influential, um, I would like to say one other thing about the AARP article. I don't know if there's an association, and I don't know if it's a correlation or a cause. Susan and I sent out multiple uh, um, certified mailings in September of 2023, and one of them went to the AARP. And hopefully, this article, inept as it is, was a result of that. So we talk about planting seeds a lot, and maybe the seed that planted grew a little crooked, and we got this weird paragraph in here. But I'd also like to acknowledge this. It's a remarkable thing that AARP has this article in their journal at all.
Oh, that's a good way of putting it. Is Dr. Guest on the show here anywhere?
I am. I had
Oh,
some
good.
audio trouble
Oh,
when I
okay.
first
There
got
you
on,
are.
but I am here. How you doing, Dr. Tennant?
Good. I'd like to get your view of what AARP said, and you're a PharmD, and you, obviously they blame the pharmacist if somebody abuses opioids. They blame the doctor. They blame the drug. They blame the pharmaceutical company. But where's personal responsibility here?
Well, this is America. We don't have personal responsibility anymore. We're a country of blaming somebody else. Um, and I'm not quite sure when that came about, but nobody takes personal responsibility anymore. That might, indicate a personal flaw of some kind. I read through this article, and I was looking at some of the citations they made and the definitions they used, and then just recently, just now, I'm looking at the authors. Are any of them physicians?
I don't think so.
I
No.
don't think so either. When you look at the footnotes behind each one of their names, um, there's nothing about them. They're associated with a health science school, but none of them are physicians. None of them have MD behind their name. Um, I don't know if it's all done in the UK, but I'm pretty sure they still call physicians in the UK doctor. Uh,
Yes.
so I concerned about that. I look at the published date on this. It was accepted in June of 24. Yet when they do some of their diagnostic criteria of what involves a opioid use disorder, they're citing the DSM-3. Well, we're on DSM-5 now, so they're using old data.
Yeah.
They
Let me just ask you. I see where you're going here, and I'm delighted. Tell us they're using this term opioid use disorder in the government reports,
Mhm.
and we don't use the term addiction anymore. We don't use the term dependence. Opioid use disorder. I think it's very important that what is opioid use disorder, and it seems to me we've got some people out here in this country want to make everybody who's using an opioid use disorder.
I'm glad you asked that question because, and you, in all transparency, you gave me a head start on it. um, I looked up the definition of opioid use disorder from John Hopkins, Yale Med, Cleveland Clinic, Mayo Clinic, National Institutes of Health, and any other source I could find. And I've got a copy of the DMS-5 here on the diagnostic criteria for opioid use disorder. And when you read all of the different criteria, it really comes down to a very simple statement, and one that you and I have heard for decades at places like Pain Week: continued use despite harm.
Sure.
That
Yeah.
is the simplest boiled down definition of opioid use disorder.
Yeah. Well, no, that's legitimate, don't you think?
Absolutely. Unfortunately, they included two boxes here I don't agree with, but because they want to include tolerance, and they also want to choose the fact that whatever substance you're using causes withdrawal as one of the part of the diagnostic criteria. And then again, as Dr. Ibsen and you and I'm sure you and me, and I'm sure all the people listening right now know that tolerance and withdrawal are just natural responses to an opioid. It's not doesn't have anything to do with addiction or use disorder.
And a couple of other drugs too.
And a couple of yes. Yeah, but you tell a diabetic that you're going to take away his insulin, and he's going to experience the withdrawal symptom of his blood sugar shooting up.
Mm-hmm. Yeah. Do you feel, from what you've seen, not only with this report we're talking about here, but others, have we just suffered we go back 25 years to the pain's the fifth vital sign. Pain is encouraged. You're condemned if you don't treat pain. Everybody wants to. We don't want anyone to die in pain. We want people to have their suffering relieved. Then all of a sudden, it's changed. Now,
Yes.
and uh, and again, we had to have some propaganda somewhere to turn society against us.
I don't exactly know where it's coming from. We've created this opioid epidemic, which is really not quite true. It's just the same percentage of a particular side effect of treatment of one drug or one class of drugs that has been known forever. Um, I I don't know what triggered this or why so many people are against treating pain anymore. Obviously, people who don't experience pain. When it comes to Kolodny and Prop and his group, I think they own too many addiction centers, so they want to make it they're just trying to generate income. Um, I just am flabbergasted by the fact that we have decided to villainize anybody that's in pain. As I say, it's our latest four-letter word.
Right. Mark, again, I'm going to ask you the same thing. And maybe I've asked this a lot of times before, and I'll probably keep asking it. Where
Keep
and
asking.
how and why did this propaganda movement start? Because it's been big. I mean, it reminds you of how they turned the Germans against Jews in the 40s. It was massive. We've had a massive change of attitude in the public. Like I say, they now believe that no doctor should be on any committee, right? No doctor should be involved with a report. In other words, doctors who treat pain or deal with opioids were bad folks. And how did they get this done? Okay,
Dr.
Yeah,
Tennant, can I interrupt for just a moment?
you're not
take it.
interrupting. Go ahead.
I'm sorry, Dr. Ibsen. It brings back to something you said when I was working with you many, many years ago. Don't find a cure or a treatment that costs too much money, or the status quo will revolt against it.
Interesting.
And I think when we made pain the fifth vital sign, when we started encouraging people to treat it, and we started to encourage patients to seek proper pain treatment, it started costing the third-party companies and the insurers a ton of money. And that just goes right back to what you told me many, many years ago. Don't find a cure that's expensive.
Well, opioids are
I have
pretty
an additional theory.
So back to you, Dr. Ibsen.
Yeah, Mark,
Thank you.
weigh in, baby.
One of the one of the things about that's upsetting to me, first of all, I think the root of this comes back to the Puritans and the Calvinists who found our country. And they were seeking religious freedom, but they were seeking freedom to practice narrowed, dominant patriarchal religion. So essentially, our country is founded on an idea that somehow somebody might be happy, and we must do something about that. So 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 it's about restriction and scarcity, et cetera, et cetera. So that's my theory about what's in the DNA of our country from the beginning. Um, the other thing I noticed, as I had colleagues when the fifth vital sign conversation came out, I had colleagues that wanted to push back violently against it. They did not like us as ER doctors being vulnerable to press ganey summaries asking about whether we addressed their pain or not. I liked it because I like to treat pain. But I had many colleagues who just basically, I'm just going to say they crawled under their rocks for a few years, and when they got the opportunity to retaliate, they took it. They felt like this fifth vital sign thing was jammed down their throat, dictating how they had to practice medicine. In the same way that I think that the opiophobia is jammed down my throat. So there are oppositional desires in some of my colleagues that say anything I can do to get out of treating this pain thing, I'm going to do it because it's complicated and I don't want to think about it. It's sort of like renal tubular acidosis. Who wants to think about that? So it's like it's complicated and we don't want to deal with it. Most of my colleagues. That said, I have an idea about the fifth vital sign. Let's go to the fourth vital sign. All of my undertreated pain patients are hypertensive and nobody gives a shit. What is that about? You can't treat pain you can't treat blood pressure from pain with an anti hypertensive. They don't respond to it. So they're on 3 or 4 or 5 hypertensive drugs and they still are 180, 190 over 110, and they're very hypertensive. And when you treat their pain, their blood pressure goes down. And we have had this campaign to treat hypertension for 50 years in this country. And now we're ignoring
That one
hypertension.
mentioned the pain, yeah.
Perhaps it is, you should say that it is that instead of a fifth vital sign, that pain is incorporated in all of the 4 vital signs, what Dr. Ibsen is
Exactly.
saying. That it is
Exactly.
exactly. And it looks like what they're doing, Doc, I must read your mind here, but it looks like what they have done is they're promoting the acronym, the old, somebody's promoting the opioid use disorder to get this acronym going so that they can, say, hey, I've developed, but it doesn't make any sense. I'm just want to let's throw it in there real quick.
Thank you.
Well,
All right.
It doesn't
back
take long
to
to
the
read the
original
We're going to
purpose of
shut
the
off this
podcast right here.
discussion. We're going to come back to the propaganda and opioid use disorders recurrently because it's a major affront to society. Right now, we've got our bright fellow from Phoenix here who is out to help us all with his lawsuit, and I've asked him to come back on the show today to give us a little more of an overview. David, where are you?
Right here.
There we go. All right. I've heard nothing but great things about your pitch, and everybody says what a bright guy you are. Anyway, bottom line is, in the time we have left, first off, give us an overview of the 2 or 3 things you're trying to accomplish in this lawsuit. Okay, you're the only person who's got it this far in some respects. What is it you're trying to accomplish?
Okay, well, aside from my personal claims for harm, I'm sorry
Yeah,
about the loud
yeah.
talk.
You don't count anymore, David. What are you doing
Yeah,
for the
I
rest
don't
of us?
count. So aside from those, the first issue I brought up was that if you ask me, the publication of the CDC guidelines was in violation of 42 USC section 1395 from the Medicare Act, which strictly prohibits federal interference with the practice of medicine. Okay? That's the
Good.
first thing. So the second thing is, after a couple of years, Congress then authorized the CDC to work with it might have been Department of Health and Human Services, because of the public emergency was declared about the opioid crisis. So then I assert that, okay, fine. They want to save people from deaths caused by overdose, which are caused by the illicit fentanyl analogs. In what universe does that pass the rational basis test of the due process clause? Our constitutional rights have been violated. We've been deprived life and liberty without due process. So that's the second thing. And the third thing would be that I claim that the DEA and DOJ are also in violation of 42 USC section 1395 because they had enacted dose caps, they're enforcing dose caps, medication combination prohibitions, and they keep arresting our pain doctors even though the Supreme Court told them to stop doing it. So they are abusing process. So that's their violation. So they can tell it to the judge, right? Explain their actions to the judge.
When do you get this opportunity?
Well, I don't know. I talked to my attorney friend in Southern California the other day and asked her, could the judge refuse to docket my case even if he didn't find any deficiencies in my complaint. And she said, well, the short answer is yes. We all wait on courts to do what they want when they want. So I have no idea when this will hit the docket.
Mm-hmm.
So we're playing the waiting game.
Right. Uh-huh.
But the key thing to say is it's not been prohibited from the docket.
No, not yet.
Yeah.
There's a component here that I think me and Dave talked about. It's so important here about this so-called opioid crisis. And what we've been able to find out is that this crisis starts at the same time when you had the heavy production of opium, poppy growth in Afghanistan. And who controlled it? We came across the cigars report. We see that when the United States went into Afghanistan, the production went to 1,000 metric tons. They were making $3.5 billion in the Afghan economy. Look at that cigars report, and it coincides. And this stuff was, this had DEA Corporation, Department of Defense Corporation, and it coincides with this increase of opium of heroin, where it starts, where 99% of this opium that was produced in Afghanistan, controlled by the United States of America, and funded by our government, and with the Afghan government, 99% of these 1,000 metric tons went into heroin production, and most importantly, the nearest state that produced that amount of poppy was Colombia, and I think it was like 50 metric tons of so when we looked at this thing, then comes fentanyl along, because you don't have to, with fentanyl, you don't have to prime it and put it in the sun and grow it and all that kind of stuff. That starts, somewhere around 2010 or 11. We have to draw those correlations here, and I think we wrote an article about this, and I handed it to Dave, and Dave looked at it and he put it in his report. He says, "Listen, there was some mischief by our government, particularly our DEA, where in fact we paid when the Karzai, every part of the Afghan government was corrupt, including Karzai. There's one guy, Karzai's brother, who the FBI or good FBI caught, and then they wanted to arrest him, and we paid $147 billion to the Karzai government to keep him from getting arrested. And you're going to blame this on the doctors, the physicians? Right. No, they're covering up for their mischief. And that's all I have to say. I'll hold my peace.
Yeah, very good. David, you've done so much work to put this together, and you know details of the legal system. You were in it for a long time. What are your plans now, whether you get a hearing or whether you don't? What do you plan to do with this information? It is so good and it's so educational.
Well, I was supposed to record a podcast yesterday with a podcaster, but it got delayed till Friday. I've been trying to get media coverage, because if an attorney would step up and help me with this, I did not go so far as to charge anybody with fraud. I just said it's either negligence, because fraud is a whole nother hoop you have to jump through. But we have evidence. A lady named Julie Cassell on Twitter has documented all of the conflicts of interest with the prop doctors and their possible money influence, conflict of interest. And if an attorney would help me, he could amend my complaint and actually file criminal charges against some of these people for some of the things that have happened. I can't do that as a pro se litigant. I've already notified the Department of Government Efficiency the Department of Government Efficiency, HHS, the Senate House Subcommittee on Health. I mean, everybody's been fully briefed. I just keep hammering them over and over. So
You have, you just mentioned something that I haven't heard brought up for a while, and that is the economic interests of the prop doctors.
yes,
Is that something you could bring to us?
I have not had time to scour Julie's old Twitter account, which I think she took down, and she's been communicating with me lately about look at this, look at this, look at this. And we suspect that the prop doctors have financial interests, either stock ownership or some other relationship with the makers of Suboxone and buprenorphine. And of course, we know they have, their addiction treatment practices, right? So these are things that need to be looked at. Absolutely.
Okay. Well, very good. Well, we'll want an update regularly on this.
Yes.
Jamie, you said at
Sure.
the end you were going to show us an X-ray or something of David's.
Yes, sir.
What is-
Yes.
My name's David, a scoliosis patient with 2 radical back surgeries 30 years apart, and I have arachnoiditis, cauda equina syndrome, leg length discrepancy, 18-level spinal fusion all bolted into the back of my pelvis, a migrating pedicle screw that's making its way out of the back of my left iliac crest pelvis area because of mechanical forces, as you can see in this picture. And I want to talk about the CDC lies, the 2016 guidelines, the data that they have manipulated and misrepresented, the unlawful, tortious, and negligent interference with the practice of medicine that is a violation of USC Section 1395, and my lawsuit under the Federal Tort Claims Act against the directors of CDC, DEA, and DOJ. I filed a Federal Tort Claims Act for harms caused to me by the negligent 2016 CDC guidelines. And the next stop is Federal District Court. That case is due to be filed in mid-February. My contention is that the CDC's 2016 guidelines became a de facto document of rules and regulations in violation of USC 1395 because it is unlawful for any federal agency or employee to interfere with the practice of medicine. The DEA continues to arrest our pain doctors for the crime of treating pain without having met the evidentiary standard necessary as set forth by the Supreme Court in the case of Ruan versus United States in 2022. And they continue to use paid expert witnesses to convince juries of guilt when there is none. So I'm going to explain the whole situation to the judge at the district court in the Fifth Circuit and lay out all of the corruption that's known, documents that are in the public domain showing possible conflicts of interest between these addiction psychiatrists who created the 2016 guidelines, who have never treated pain. And these agencies can tell it to the judge. I'm done with the torture. People are being tortured to death in hospitals across the country right now. Chronic, intractable, cancer, end of life, and surgical pain patients cannot get proper, appropriate opioid pain medication, or anxiety patients can't get benzodiazepines, and now ADHD and fatigue patients cannot get stimulants, because the DEA seems to think that the definition of a controlled substance is a substance that you can't have anymore. So they're ignoring the fact that these medications have legitimate medical indications for patients who are severely injured, ill, and who have been having surgery. And they're torturing people to death. Patient outcomes have not been tracked. Thousands have already died. The pain lawsuit.
Mark, would you like to say any one last thoughts about everything we've heard here tonight?
Yeah, I want to report on a miracle. I have a Board of Medicine meeting tomorrow, where I don't know if I'll be suspended or not. But it's an escalation in the hostility between me and the medical board in Montana. And unbeknownst to me, a letter writing campaign happened, and there's something like 97 letters been sent to the Board of Medicine, which has flummoxed them, confused them, irritated them, and they are forced to share these letters with the board members in Montana. And I want to express my appreciation to everyone who wrote a letter to the medical board. This hearing tomorrow is about HIPAA, so we can talk about pain all we want because it's not on the schedule. So it's a great thing that happened, and I'm very, very grateful and touched. I feel like George Bailey at the end of It's a Wonderful Life. So thank you. I'm honored and moved. And I'm going to go in there tomorrow and be forceful and not too dramatic. And we'll see what happens. So thank you so much for everybody.
And Dr. Tennant, what confuses me about the thing with Dr. Ibsen is that what he was discussing was the manner of death. And I'm going to ask you, since when is the manner of death a protective part of HIPAA? And that's what concerns me. He talked about suicide, and that to me deals with the manner of death, not with protected information or the manner of health. And so I was kind of confused. Mark and I talked about this yesterday about, the patients he described. 3 of them had committed suicide, and then 1 had overdosed and on some amitriptyline, I believe it was. And I don't quite remember what the other 2, but it seems that in his discussion that was public, that is the manner of death and not anything that's protected with in terms of protection. So I'd like to get your curiosity on if I can, I'm not on the schedule, but thank you. So, I just want to get your curiosity on how it is they could confuse manner of death with HIPAA.
Norm, that's a nice way to end this show. Let me just say that I thought I would make a lot of friends years ago. I was a great student, if you will, of Kubler-Ross, Dr. Kubler-Ross, and took the belief, and that's why we're doing this program, and that is no one should die in pain, and no one should have to stay in bed or suffer rather than have a good quality life when easily available medicines are available. And I think that's a philosophy we've done here. The thing and Mark, good luck tomorrow. I hope we're turning the corner. That's why we've got this podcast. That's why we're going to write letters. We're going to call out publications. In other words, let's just, it's very clear. No one should die in pain in this country. No one should have to suffer needlessly when medications, pharmacists, doctors, nurses, PAs are available. And let's just call it that. And let's just we just have to turn this ship around. That's all there is to it. We started. Mark, tomorrow I think it's going to go well, knowing you and knowing all the people that are behind you. And we're still going to be behind you, and you're still going to be with us, okay? All right, with that,
Thank
folks,
you.
again, Jamie, thanks again. Everybody who's been here, Scott, Norm, everyone who's participated. We'll see you next week. Good day.
My pleasure. Good night.
Thank you.
I love you all.
Love you too, Dr. Ibsen. Thank you.
Good luck, Dr.
You're with
Ibsen.
me.
Good luck, Dr. Ibsen.
We'll be praying for you. Yes.
Thank you.
Yes.
Thank you.
Donna, would you say a prayer for me?
Of course.
Yeah, Dr. Ibsen.
Yes, certainly. Dear Lord, please, all of us here are thinking of Dr. Ibsen and admiring his courage. We know that you are behind him because he has a heart filled with love and all the doctors who are here. So we just ask you, Ibsen, as he goes to testify tomorrow, Be with him. Surround him with your angels, the angels that will fight for your kingdom, because he is bringing people together who are in pain and helping them be free of it. Please be with him. And thank you for all you're doing for all of us. Amen.
Amen. Amen.
Man, thank you, Donna.
Thank
And-
you.
Dr. Ibsen, did that meet your specification today?
It did. Yes.
All right.
No HIPAA violation occurred in that prayer.
Thank you.
You're not alone, Dr. Ibsen. We love you.
Thank you.
We love you.
Love you, Dr. Ibsen.
Dr.
Yeah.
We're with you.
Dr. Ibsen,
Yeah.
did you see that someone said they were a HIPAA consultant for 10 years?
Was that Robert Payne?
Yes.
Yes. Okay.
Okay,
Thank you.
good. Okay.
Thank you. Anybody have his contact number? Send it to me.
Did
Thanks.
that article that we reprinted by Bob Sheeran, did that help?
Yes, very much.
Thank you.
Thank you. Thank you. God bless you.
Thank you, Donna.
Bye, everybody.
Bye.
I just wanted to take a brief chance to mention something to everyone that's been really helping me with my AA symptoms. Is that I have a infrared and near infrared light therapy belt. I have been using it extensively every single day without let up, and I am telling you, it has really improved my pain.
What is it?
So it's called an infrared and near infrared light therapy belt. There's tons of them on Amazon. You know, the one, so my grandma got it for me, but it was like $60, but there are some that are a little less expensive. And actually they have a 38% discount on right now going on the particular one that I have.
Thank you.
So yeah.
Thank you.
Thank you.
Yeah.
So much.
Yeah.
Amelia, I just have a question. It's actually about the light. Is there a certain number of like lumens or however they measure it that you're using?
Sure. Yeah. There are certain things to look for sure. When getting a light therapy belt. What I've read is that yes, you do want to have a certain number of lumens. And then the more lights, the better, the less time you'll have to spend, actually using it. And yeah, I think
You use it constantly 24/7?
Thank you.
Sorry.
You use it constantly 24/7?
Oh, no. I'd say probably just about 2 hours a day.
Oh, okay.
Yeah. For myself. Yeah.
Thank you
So much, Amelia.
What brand
Thank
do
you.
you
Yeah,
so very much.
I want to say something real quickly. I've had withdrawals from other medications. They call it discontinuation syndrome. So if I have symptoms from not taking medicine that a doctor prescribes to me, I call it discontinuation syndrome, not withdrawal. I think it's just a lot less politically charged. So I could encourage everyone to call it discontinuation syndrome.
Love it. I'll do that.
I like that term much better.
Yeah.
Yeah.
Thank you. Thank you so much. We've run out of time, and thank you all for being
Thank
with
you.
us. We will be together next week.
Amen.
We'll see you with us next week, Dr. Ibsen.
I will.
Yes.
Wishing you the
Yes.
very best
Licensed or
tomorrow.
not.
Yes.
Love you guys.
Yeah.
Could be a
Okay.
consultant.
Mwah.
Love you guys.
Okay.
Kisses.